cancer itself is going to be the disease of the next decade. That's what I think. It's going now. The number one killer in the world is heart disease. Number two is strokes. Strokes is the number two killer in the world at present. And third is COPD. Can you believe third is COPD has become the third killer, and cancer is the fourth killer as on date. But it looks like in another 10 years, cancer will overtake all this and become. And in fact, every day we see cancer. Even today morning, one of my relatives, they said he has a cancer of the skin and all that. So cancer is going to be a big threat to all of us. So I asked Apollo people to, who are the specialists in this particular thing, to talk to us on simple aspects of cancer. Like, they're going to tell us some systemic therapy in cancer, robotics in cancer, because that has really come up in a very big way. So robotics in cancer, and of course proton, which is another thing. Proton, probably Chandrasekhar will be able to explain to you what exactly is proton. Is the every cell has got a neutron, proton and electron. And this proton is one thing which is positive, I think. That's positive. And that is the one they use in proton therapy to kill the cancer. They're focusing exactly on the cancer cell to kill the. So a lot of developments have taken place in cancer therapy, and we are very happy to welcome all the speakers here who are going to talk to us on this particular thing. So for a small thing, sir, all of us are practitioners, general practitioners in our own fields, practicing for the last 40 to 50 years. So a lot of rich experience we have. So we will be very happy to hear from you everything about cancer. Try to make it very simple so that we'll be able to understand it much better. Okay. So with this introduction, let us welcome the first speaker to talk to us on this thing. Let me welcome Dr. Subhashini to introduce the first speaker. We have 3 speakers today, and we'll finish up by about 4 o'clock. Okay. Thank you.
Good afternoon. Dr. Sujith Kumar Mullapally is a consultant in medical oncology, proton cancer center. His expertise and the interest are in thoracic oncology,
second speaker,
oncology, his education got his
Soft down.
from All India Institute of Medical Science, New Delhi, and intermittent radiotherapy from Delhi, and PM Medical Oncology from Tata Memorial Institute, Bombay. European Society of Medical Oncology certificate also he has received. And working experience as a consultant, he has worked in so many places, so many institutes in Kerala and Mumbai. He has received so many awards and medals in these occasions, conferences. Articles in reputed journals and book chapters in oncology. So present expertise, the area of expertise is systemic therapy, like immunochemotherapy, low-dose metronomic chemotherapy, targeted therapy, preventive oncology, and palliative care. I invite Dr. Sujith
Kumar.
Mullapally to take the lecture.
Good afternoon, everyone. Thank you, ma'am, for the kind introduction. It's my privilege to be here among experienced physicians of Indian Medical Association at T Nagar. And I think it's most important for us to connect, because many of the times we only evaluate the patient. Most of the time, the diagnosis, the first consultation is often with all of you, and you are the people who actually pick it up, understand that this may be a cancer, and then accordingly refer or evaluate, and then the whole process starts. Now, when I joined MBBS in 2001, I remember when I was in my 4th year of MBBS, I was interested in oncology, so I went to the radiotherapy department. There was no medical oncology. There was departments, but there were no medical oncology departments in government hospitals. And we had 14 days posting in the unit. So the radiation machines were cobalt machine, and we spent 2 days there. The third day, my consultant or the professor told me, it's enough, you don't need to come more, it's very busy here. We don't have much time to teach you, there is nothing much to teach you. That time there was gentian violet, I don't know, many of you may have seen. They used to mark it like this on both for head and neck cancer, there used to be 2 marks, and the radiation used to be given on both sides. There was no concept of targets, there were no concept of organ at risk, there were no concept of preventing toxicity. So that was the time when I did my MBBS, and thereafter I did my MD in All India Institute. Slowly over this last 20 years, 24 years, I have seen a lot of changes have happened. Unfortunately, as Sir said, there is increased incidence of cancer. Even in our extended families, we come to know, we get reports in our WhatsApp alternate days saying that we want an opinion. And it's difficult to say why it is happening. One of the reasons is there are, I would say 15% of the cases are because of risk factors like smoking, alcohol, etc. But 85% of the cases are many times environmental, very few are because of genetic reasons. So it is said that whatever lifestyle changes have been happening for the last 15 years, including, I come from Kerala, so we have had, there was a generation where BD was there and then cigarettes came. All those people who had cigarettes and all in the 80s and 90s, they are getting, many of the times they are getting higher risk for lung cancer. We are also seeing so many females. I am sure many of you would have seen female patients having lung cancer, and it has been seen and it has been published in Nature around few months back that air pollution is one of the causes of lung cancer, and it is especially true in Delhi. You would have known Delhi has a high rate of lung cancer, and in Apollo we have so many patients coming from northeast area. A lot of people have addictions, but many times it's also the pollution. In China, South Korea, the pollution is high and the lung cancer is high. So many times patients, when females come to us, it's, you see, the cancer is one thing. I would say diabetes, hypertension. Someone has a cardiac surgery, they are able to communicate to the other family members, I had a cardiac surgery, bypass, etc., etc. Cancer is one thing which even now carries a lot of stigma. Even patients come to me, they ask me, should I tell my family members? I say, unless your family members know about it, don't tell. They will confuse you. They will create a lot of tension. Everyone wants to advise. Even if they don't know, they may advise, don't eat this, don't eat that. This happened to my neighbor, this happened to my friend, and then you will get confused. So even as a doctor, I say, you don't tell, you just do what is needed. That 5-6 people, your husband, wife, kids, that they should know about, because you need a lot of social support, but don't need to extend it to your neighbors and all, because they may confuse you. One more thing is, the females ask us, the ladies, 68-year-olds, they come, the retired school teacher. We had a retired school teacher coming and asking me, doctor, I never did anything. I even don't eat, I drink tea. Many people think tea is an addiction. They say, I don't even have coffee or tea. How did it come to me? And then we discuss, this is because of pollution, this and that. And then I feel God has created some targeted therapies where I can say, Amma, don't worry. We can treat you without chemotherapy. We can treat you with tablets. And that is how advancement in science help us to deal with patients on a daily basis. So my topic today is regarding systemic therapy in cancer, especially advances in 2024. So I'll go through the slides. Yeah, so all of you know, management of cancer is always a teamwork. Many times it starts from the referring team. We have the surgical oncology, radiation oncology, medical oncology, oncopathology, radio diagnosis, oncology nursing, a very important specialized nursing team, pain and palliative care, physical and occupational rehabilitation, and preventive oncology. So these are the different branches I represent. I did my MD in radiation, but after that I did my specialization in medical oncology, and I am currently working as a medical oncologist. So medical oncology is the branch of oncology that deals with systemic treatments in cancer, usually administered orally or intravenously. Previously only chemotherapy was there as a treatment option. Nowadays we have chemotherapy, targeted therapy, immunotherapy, endocrine therapy. Many of you would have heard breast cancer patients, after their treatment are on 5 years or 10 years of tablets, which is basically endocrine therapy. We also have stem cell transplantation, all of you know about it. Many of you would have heard about CAR T cell therapy. And then supportive care is a very important treatment aspect. The medical oncology has benefited immensely with advances in supportive care. Previously, whenever someone says about chemotherapy, they have fear about vomiting. You would have heard patients getting admitted because of vomiting. rarely those things happens nowadays because there are very good anti-vomiting drugs which helps them to go through the treatment very smoothly. The same way chemotherapy means infection. A lot of people used to get admitted in the ICUs and used to pass away because of infection and not because of cancer, because of low WBC counts. Now you all know there is growth factors which help to improve the WBC counts, which helps us to give intense treatment. You see, the curative treatment many times are intense treatment. We can't be compromising on the treatment intensity. So we may have to give high dose treatment, and we have the support of good anti-emetic treatments and good growth factors. So to discuss about cancer, I thought I would take one cancer as an example rather than going all around, because each cancer, every patient who comes to me comes with a burden of thoughts because they have already known about what has happened to this person, that person. So I always tell them cancer is a unique thing. Each individual who are you, many of you may be medicine physicians or gynecologists or pediatricians, you all know as individual you are unique people. Nothing can define that you are similar. The same way patients are also unique people, and each cancer is a unique cancer. So I always tell them that please, you just keep whatever you know, you keep it aside. Let us discuss your cancer in a different way. So we will take lung cancer as an example to discuss what are the various advances that has happened in field of oncology. So and because why is it important? Lung cancer is the most common cancer among the males, and breast cancer is the most common cancer among females. But if you take worldwide, lung cancer holds the first position for high mortality and incidence. So we'll see lung cancer as an example for what has happened over the last 2 decades in oncology management. So many of you know lung cancer, there are 2 major types of histology, small cell carcinoma and non-small cell carcinoma, which includes adenocarcinoma and squamous cell carcinoma. And as I have said, the most common causative factor is smoking. Air pollution is coming in a big way, in especially non-smokers, and radon gas, etc., are of historical interest. So this is so anytime if you want to see about what is happening in cancer or you want to know about the facts, you don't need to go anywhere. You can go to this site called Globocan, which has the updates of cancer every 4 years. Now this is the Globocan 2020 data, which says that the breast cancer in all, including males and females, taking the number into account, breast cancer was the most common cancer, followed by lung cancer. Whereas when you see the number of deaths caused, the mortality caused, lung cancer is the number 1, which means breast cancer, still we are able to cure many of them, and many of them are long-term survivors. Unfortunately, in lung cancer, previously the 5-year survival rate for a 4th stage cancer was less than 10%. Now with immunotherapy and targeted therapy, it has gone up to 25 to 40%. So there is an improvement in the survival, but still lung cancer is the most common cause of cancer-related death. Coming to India, as you know, breast cancer again, previously cervical cancers were very common. Nowadays, because of improvement in personal hygiene, improvement in even vaccination has contributed to a bit, but in India it is much less. But breast cancer is the most common cancer in females, whereas in males, because of the habit of oral tobacco chewing, the head and neck cancer is the most common cancer. Apart from that, lung cancer comes in the 2nd position. So it's important to know the problem before we go to the solution. So it's very important. Many times as doctors or oncologists working in cancer centers, we find that 60 to 80% of the patients that come to us unfortunately have an advanced cancer. This is true even now. Why? Because the symptoms only appear when they become really what you can advance. Suppose for a lung cancer, what are the common symptoms we see? Most of the time it is chest pain or a cough which is not responding to antibiotics, or a blood in hemoptysis or blood in sputum, or sometimes the disease has already spread to the brain and they come with headache. Sometimes because of bone mets they come. So unfortunately, because we have 2 lungs and both the lungs are not required for us for have a normal function, even if there is a 2 centimeter or 4 centimeter tumor in right side lung, the patient would be, or the person would be completely asymptomatic. Unless there is a fluid, pleural effusion or a metastatic disease, they don't present. So is there a role to detect cancer early? Yes, that is what has been proven by different trials. There is what is known as lung cancer screening. Now, most of us as senior physicians, you would have been advising breast cancer screening, many times cervical cancer screening by pap smear. Nowadays, colon cancer screening is also available. Lung cancer screening has not been very popular in India because of the logistic aspects. But if you have a person who, you see, many of you are like family doctors, as sir said, 40-45 years means you would have seen generations of families coming to you. You would have known that person who has been smoking for many years in spite of your advice, and he's around 40, 50, around 60-70 years. So if you know a person who has smoked more than 20 pack years, and what is pack year? Pack year means if the person is smoking one packet per day for a year, it is one pack year. Suppose he's smoking 2 packets, that means these 2 pack years. So if suppose someone smokes for 10 years, 2 packets per year, it becomes 20 pack years. Suppose you know a person who has 20 pack years or more history of smoking, and they are between this age group of 50 to 80, they are definitely going to benefit with a lung cancer screening called low dose CT. Now, low dose CT is little different from the normal CT, but any hospital where you see when for the first time in my last 25 years, I saw stage 1 cancers when it was COVID. Patient used to go for COVID screening, then they say there is a nodule 2 centimeter in your right lower lobe. Please get it evaluated. Biopsy came positive. Get operated. Stage 1 cancer. No further treatment. After that, 2020, 2021, we have seen at least 4 or 5 patients who have come to the hospital with the first stage of cancer. Never before, never after. Why? Because the CT became so much common that time. People were used to do CT index and they used to find what is happening with the COVID. So there is something known as low dose CT. So this is the criteria. 50 to 80 years who have 20 pack years smoking history and currently smoke or have quit within 15 years. So 15 years can be considered as an incubation period. Suppose someone has stopped smoking before 15 years, still had a lot of smoking, we can safely say that they are more or less not going to get smoking related lung cancer. So if you have someone who has quit smoking, many of the times the reason patients have quit smoking is a cardiac illness. Suppose they had a cardiac CABG or they got a angiogram, then they stop smoking. And if they have this, they are in this criteria, please consider to do a CT chest. X-ray doesn't help, sputum microscopy doesn't help, nothing else helps, CT can help. And there is a rider to it. If you are doing a CT scan for these patients, always do it when you have a team of interventional radiologists or a pulmonologist who can take biopsy. It has been seen that improper biopsy of patients, or they are not yet patients, improper biopsy has caused pneumothorax and has caused death when they undergo screening for stage. So if you have a good team or you have a referral interventional radiologist who can do a biopsy for a 2 centimeter lesion, please go ahead and do a CT screening for these patients. And it's an every year thing. And you can stop smoking, stop screening once that 15 years cutoff is there, or if the patient has, suppose the patient has a bad cardiac illness that he is bedridden, you don't need to do a CT because it may not change the way he is going to be treated or evaluated. So if a person is fit and fine, history of smoking more than 20 pack years, between 50 to 80 years, please, if you know someone in your family or you know someone in your friends, it is very safe to do a CT once a year to find out whether there is lung cancer. Now previously it was 55 to 80, now it has become 50 to 80, and 30 pack years was the cutoff before, now it is 20 pack years. It has been seen that the percentage of stage 1 and stage 2 cancers are nearly doubled when you do a staging CT and find the cancer. I say the patients of lung cancer, if I see 10 patients in 2 months, I would say nearly 2 of them may be early cancer. 80% of them are advanced disease, many times very advanced disease with brain mets and liver mets. So there is one way that as the community, as the people who are seeing the patients for the first time, you can make a difference by considering evidence-based CT for these patients. So now we'll go to, again, small cell carcinoma has not had much difference of treatment. Recently we had immunotherapy, but I will be focusing on non-small cell lung cancer because that is the most, 80-90% of the cancers that we see are non-small cell lung cancers. And we'll have some basics. And targeted therapy. What is targeted therapy? Many of you would have seen reports of what we call as liquid biopsy. What is liquid biopsy and what is immunotherapy? As sir mentioned, I have kept it very simple so that we can have some questions at the end of the session rather than me showing so many data. So treatment of lung cancer, all of you know we have AJCC staging. We have stage 1, stage 2, stage 3 and stage 4. Stage 1 and stage 2 is considered as early lung cancers. Stage 3 is usually locally advanced, and stage 4 is advanced lung cancer. Usually stage 1, 2 and 3A undergo surgery, and many of them, especially radiation therapy. Dr. Nagarjun is here. Radiation therapy is a very useful treatment, that is radiotherapy is a very useful treatment even in stage 1, especially when they have medical comorbidities which prevent them undergoing a thoracic surgery. So there is something known as stereotactic radiotherapy, where for 3 or 4 sessions of radiation can give the same result as surgery, and it is an OP patient treatment, 4 or 5 visits to hospital and the same result. So, but they have to be medically inoperable most of the time. Coming to systemic therapy, in chemotherapy role is usually from stage 1 to stage 4, and there is something known as adjuvant, concurrent and palliative, and also there is targeted therapy and immunotherapy. Previously, targeted therapy, immunotherapy was useful in only advanced cancers. Nowadays, even in early stages, we use immunotherapy to reduce the cancer and to make surgery more easy. So this was the if you see, this is an article in 2001 which was showing current standards of cancer care in small cell and non-small cell cancer. So 2001, you can see this single chart, and most of them, 100% of them are only chemotherapy. So this was the treatment options which was available nearly 25 years ago, and now you'll see this is what many of you would have seen, the NCCN. It's basically a guidelines from the US which helps us to understand, or maybe it just puts the standards for how to do the workup for patients who are diagnosed with cancer. So we have, suppose we have an advanced or metastatic cancer. Most important part, as you are all going to see, as someone mentioned, you are seeing on and off every day. The most important thing about lung cancer is, previously an FNAC was enough. Just an FNAC, okay, cancer. When I was doing my MD, either it's small cell, non-small cell, that's enough. No pathologist used to go beyond that. And the treatment starts with chemotherapy. Now we have to understand we need enough biopsy material, because it's not only the pathology report, but also what we call as molecular pathology, which has made a big difference in how we are going to manage the patients. So we need to have enough tissue. So the pulmonologist or the CT person who is done, radiologist who is doing the CT guided biopsy, has to give us enough tissue so that we can do the molecular analysis. Why is it important? As you can see on the side, on the slide, that box actually is around 11 or 10 tests that we are going to do on that biopsy, especially in adenocarcinoma. Now, adenocarcinoma is increasing. Previously, most of the time, smokers, usually they get small cell carcinoma or they get squamous cell carcinoma. Very rarely they get adenocarcinoma. Now, which females, non-smokers, or males who are non-smokers, they get what we call as adenocarcinoma. And adenocarcinoma, most of the time, nearly 60 to 70% of the time, they have targeted therapy options. So suppose you get a report for an opinion regarding some of your close friends or something saying adenocarcinoma and stage 4, they might be very upset because of stage 4, but please remind them stage 4 adenocarcinoma has excellent survival because many of the times they have targeted therapy options. How do we know which target to use? This is what we do. We do what we know as next generation sequencing. Basically, it's like in COVID times, we had a specific PCR for COVID virus. Here it's a multiple PCR for different genes, and there are at least 10 or 12 genes which are found to be useful for targeted therapy. So that is how we do. It's an NGS. We in India are fortunate that these tests can be done even up to 20,000 or 15,000. These tests are available in the industries are there, or companies are there who can do it for 20,000, and that makes a difference for that treatment. So this is called as NGS. This is the way and in squamous cell carcinoma also, if they are non-smokers, we can do the test. Otherwise, mostly they don't have this. The other test which is known as PDL1 or PD1. PD means programmed death. So programmed death, you would have read about apoptosis, etc. Programmed death ligands are a mechanism of cytotoxic T cells. How do they kill the cancer cells? There is a test like IHC. Many of you would be aware IHC. We say for breast, ER, PR, HER2. The same way, we have a IHC test called PDL1. If your PDL1 is positive, there is a good chance that immunotherapy will be effective. So apart from the molecular test, we have to have immunohistochemistry for PDL1. It is done on the tissue again. So these are the different tests that are done. It's an essential workup for NSCLC. So this is what, as I was telling, there are different platforms for target detection, molecular tests, Sanger sequencing, or specific PCR like we used to do for COVID, and next generation sequencing. Next generation sequencing is a massive parallel sequencing which gets us more information regarding the target that is available. So what is liquid biopsy? Now tissue biopsy is the standard of care for cancer diagnosis and cancer molecular tests. Now suppose there is a patient, a very elderly patient, somehow he is COPD, somehow the pulmonologist managed to get a biopsy from the, and the patient had a complication, went into pneumothorax or something and just is recovering. The pulmonologist says this is the only thing I can do. It's a central mass. There is no way we can take a repeat biopsy. That time, how do we manage? That is how we do what is called as liquid biopsy. Now, what is liquid? That is basically means the blood. So 4 ml of blood can be utilized to do the NGS, and that is known as liquid biopsy. Again, we have different companies doing it, and usually in 10 days time the results come. The only thing is, usually they are positive only if it's a metastatic disease. Now, what does it mean? You see, whenever there is a cancer cell growing in the body, there is continuous growth and death happening. You know, even our body, even if there is no cancer, daily normal cells are growing, they are dying, so it's on going on. In cancer cells also it's happening, and the blood that is flowing through the cancer many times takes these cancer cells along with it, or the cell DNA along with it, which can be detected by highly specific tests. So we can detect the circulating tumor DNA and do the tests on it. That is known as liquid biopsy. So this is what it says, though. This is a molecular assay involving circulating tumor cells, circulating tumor DNA, circulating exosomes, and tumor RNA obtained from blood, CSF, and other bodily fluids. We can even do it in CSF. So this has been studied in different platforms, and this is what basically it means. As you can see, there is a tumor tissue. From the tumor tissue, the circulating DNA is going, and it is all. That is how many times metastasis happens. The cells are in the blood circulation, going to the liver, getting filtered there, going to the lung, getting filtered there, and then growing as metastasis. So you can see that in the cartoon, you can see that tumor tissue is giving away the circulating DNA, which is collected on a 5 ml of blood, and then it is being tested for NGS. So this is known as liquid biopsy. So even if you know someone who has a biopsy, not enough material, this is a very common test that can be done. It is available in different platforms. Again, it comes in, we have lung cancer, this liquid biopsy for 22,000. Yeah. So there is, because of this competition between different platforms, different companies, it has become very cheap. Previously, it used to be more than $1 lakh, and there were only 2 companies where you have to send it to US. Now Indian companies are doing, and we get very good results within 10 days. So the good thing is that there is no, you see, how do the tissue biopsy goes to the pathologist, they make the paraffin block, then the block goes to the molecular pathologist, they extract DNA, then do the PCR. Here the liquid biopsy, automatically it goes to the DNA is extracted, directly it goes to then, usually 22 days is the usual time for turnaround time for the biopsy, tissue biopsy, it comes in 10 days. Yes, we do it especially two times. One is when we have a disease progression. Many times the disease progresses, the biopsy is not accessible again. It may be deep within the lung, or it might be in the brain. So we do the liquid biopsy. Second thing is when the tissue is inadequate. And also one more indication has come. Now suppose we have a stage 2 colon cancer. Now stage 2 colon cancer means T3N0 we say. Usual dictum is if it's a stage 3 colon cancer, no doubt, they need to go for chemotherapy. Suppose we have a stage 2 colon cancer, there is something known as low risk and high risk. Now how do we decide how to give chemotherapy, when to give and not? Previously we used to go by whether the patient came with obstruction, whether there is a lymphovascular invasion, whether there was an ruptured tumor. In that case we give chemo. Nowadays there is a data saying that you do liquid biopsy, you send it for this test. If there are no circulating tumor cells in the blood at the end of 4 weeks, then you can safely avoid chemo. You see, this test may cost around 1.5 or 2 lakhs, and chemotherapy total may cost around 4-5 lakhs, apart from the toxicities. So some of the patients do prefer that. You do 4 weeks later, do this test, the report comes negative, no tumor cells in the blood, you can avoid chemo. that is very specialized. In India, there are 1 or 2 labs. Most of the time, the validation has been done in international labs. There is something known as Garden, Foundation One, etc. But it's available. Again, they have tie-up with the local labs. They do the test for them, and accordingly they do the logistics. So it is possible. So this was the lady who had come to me. She had 68-year-old lady, retired school teacher, non-smoker, had a neck pain, went to the orthopedician. The orthopedician did an MRI neck, multiple bone mets, and X-ray suspicious lesion. The PET scan showed hyperbotoma. So again, PET CT, you would be seeing there are a lot of use of PET CT nowadays, most of the time, and it is in a way useful. Previously, CT thorax, CT abdomen, bone scan, MRI brain. This was the way we have to do. Now, PET scan can replace CT thorax, abdomen, and bone. But in case of adenocarcinomas, lung cancer, we have to do MRI brain because the PET CT's resolution is less than 1 centimeter. It cannot be detected on PET CT, especially brain. The PET CT works on the principle of metabolism, which that is high metabolic activity. You can't detect small lesions, and brain always lights up because of the metabolic activity. So MRI brain is part. So this PET scan showed there is lung mass. There was a biopsy, adenocarcinoma. TTF1 is a specific IHC marker for lung. And then MRI, no evidence of metastasis. So she was planned for NGS with a 50 gene panel. This is the report. You see, this is the metastatic disease. You can see multiple areas of mets, and EGFR mutation came positive. She was started on, she was very frail. She was started on, we started her on erlotinib, and she went on for 1.5 to 2 years. Then she progressed, and she had to go for chemotherapy. Altogether, she was able to live a good quality of life for around 2 years. And then she passed away. But the family was happy because being a stage 4 cancer, she spent a good time without any chemo, without any major problems in her quality of life. So for oncologists and for the family, both the cancer care should include a good quality of care also, quality of life. You can't be doing a very intense treatment and the patient is sick and all the time in the hospital. Doesn't make sense. So quality of life also is very important. So this was the plan: EGFR directed treatment, palliative local RT for the bone mets. There are injections called bisphosphonates which are given for osteoporosis. They are also useful in lung cancer, in other cancers with bone mets. So this is how we choose the treatment. I will not go into the details. So this is actually osimertinib is the drug of choice. Now osimertinib is a drug which costs around 1.25 lakhs per month. But there are other drugs like afatinib or dacomitinib which costs about 10,000 per month. So there are options. So that is again another big stigma in people, that whenever there is a diagnosis, they fear that all the treatment is going to be very costly. Again, because of Indian generic market, a lot of patients are able to afford the treatment because there are treatment as cheap as 5,000 per month which can be utilized for their benefit. So it is important. There is no awareness. I'm sorry to say that even in my non-oncology friends, young people who would have learned about it, or even in people who are in practice for many years, there is a lot of nihilism. Whenever someone is, so even my wife is a pulmonologist, so even for her residents, some diagnosis happens, stage 4 cancer, they say, Madam, morphine koduthu veetlekku vittu. That is what they are saying, give morphine, send them home. So that is not the thing. Pleural effusion, bone mets, brain mets, still they can have 1 or 2 years of good life, good memories for their family. So this is another mutation. Again, I will not go into the details. ALK mutation, which is very useful. The survival, you see, the survival, I said 5-year survival is 20% in stage 4. These are category of patients who have 5-year survival, which is around 8 years. So you can see for a stage 4 cancer to have an 8-year overall survival is very good, which was unheard before. So again, these are the different. So these are the molecular subsets which are saying there are a lot of molecular subsets which have targeted therapy. So you see, these are the drugs. You see, 2001, I said only chemotherapy. From there, you can see how many boxes are there. And every year, there are new drugs, immunotherapy, targeted therapy. They may take some time to come to India. Sometimes it takes 1 or 2 years, but it can be imported. But even then, we are able to utilize most of the drug. Unless they are in clinical trial, almost all of the drugs are available, either imported or otherwise in India, to be used for our patients. It's a scientific revolution in a way. So this is what is known as targeted therapy. So we have discussed targeted therapy. Targeted therapy is nothing but oral, most of the time oral medicines which are given based on next generation sequencing which can be given as an oral therapy and have excellent response. What is the benefit over chemotherapy? It doesn't have the side effects what happens with chemotherapy because it's very targeted. But still there are very typical side effects, especially skin related, nail related side effects. Some people have diarrhea which need to be managed. So these are the main side effects which we see. No blood count issues, no fever, no hair loss, nothing happens with the targeted therapy. Coming to immunotherapy, as we all know, we all have these cancers are developing in our own body. And you see, when you have an attack of teeth infection, you get lymph nodes because the lymph nodes or the immunity identifies as a foreign body and it attacks it. So why is it happening that there is a cancer growing in the body and the cancer is not being detected by our own immune cells? Our own immunities, I always say our immunity is actually the most important thing, which not the immunotherapy. So it is because whenever there is a cancer cell growing in our body, the body identifies these cells as our own cells. It doesn't identify them as foreign cells. It is true, it is our own cell which is becoming bad and becoming cancerous. So what happens is there is a break on the immunity to prevent any attack on these cells. So there is an auto break where the cells don't get attacked by our own immunity. So this causes the cancer to grow in leaps and bounds, and that is how it goes to a situation where it becomes symptomatic. Now, immunotherapy means using the body's immunity to fight against the cancer. So there are different forms of immunotherapy. It is now considered as a scientific breakthrough of the decade. Few years back, the Nobel Prize went to the scientists who invented or discovered the immunotherapy treatment options. Now, so this is a traditional treatment, radiation or cancer. Side effects are many times more and post-treatment protection is very less. Whereas in case of immunotherapy, side effects are typically minimum and even after the treatment is over, because it is related to the immunity, it works well. So immunotherapy is any treatment to boost or restore the ability of immune system to fight cancer, infection and other diseases. Different immunotherapies are there. We'll come to, so this is a different immunotherapy types. This is how basically the immunity works. There is release of cancer cell antigens, cancer cell antigen presentation, then priming and activation, trafficking of T cells, infiltration of T cells, and recognition of cancer cells by T cells. Now these are the main immunotherapy: anti-PD-L1, PD-L1, nivolumab, pembrolizumab. These are all monoclonal antibodies or MABs, and anti-CTLA4. So basically what is happening is these drugs, when they are injected to the body, they go and put what we call, they are known as checkpoint inhibitors. So what has happened is there is a break on the mechanism of immunity against the cancer. These drugs go and release the brake, which causes the cancer to be attacked by the immunotherapy. So the immunotherapy drugs per se don't kill the cancer cells, they activate the immunity and that causes cancer. So there are situations where stage 4 cancer patients, no chemotherapy is working, patient is being declared, nothing can be done. They go for a trial of immunotherapy and they live for 3-4 years more. So there are patients who have, yes, it's like biologicals. It's like biologicals. Only thing is it activates. It's not like a monoclonal antibody, typically like what we used to have in basically in breast cancer. We use trastuzumab. It is a monoclonal antibody which goes and blocks the receptor. Here there is no direct receptor. That's a target actually. Here it's like uncontrolled activity of the immune system. By this, basically they are checkpoint. This anti-PD-L1, PD-1 is a checkpoint. CTLA4 is a checkpoint. So they are checkpoint inhibitors. They reactivate the immunity and it causes effects. So I'll come to the side effects. So side effects. So now immunotherapy is useful. First it was useful in melanomas. Now it is useful in lung cancers, esophageal cancers, GI cancers, even in case of Hodgkin's lymphomas, etc. Immunotherapy is being very much useful. So again, the logistic things are there. Cost is an issue, but because of the competition between different companies and different drugs available, there are patient support programs which help. So side effects of immunotherapy are typically like autoimmune disease. You can see all of this can be seen in autoimmune diseases. There can be pneumonitis, there can be carditis, there can be enterocolitis. So they are all very rare. We say typically less than 5% of patients of immunotherapy develop any major side effects. But if they develop, they do develop in a bad way, and we have ultimately to give them steroids or infliximab, etc. So we need to be very much aware that on immunotherapy there can be side effects, but they can be managed with steroids. We have to be aware. So I'll come to the summary. So in case of lung cancer, there has been a lot of lung cancer. I'm saying is a poster boy. Everyone says is a poster boy of cancer care in the last decade because of the advancements that has happened. So the cancer has to be defined not only in terms of the histology, it has to be defined in terms of the molecular workup. We need to know what is the gene which is there, which is causing the cancer. Is it targetable or not? If it is targetable, is there a targeted therapy? Is there an option of immunotherapy? So there are different areas, and I'm telling you, although I'm working in Apollo, I have friends in GMC, I have friends in medical colleges who are also treating the patients with immunotherapy and targeted therapy, because there are schemes, there are patient support program. So if you have someone, never cost should be an issue. I'm telling you, there are so many treatment in Adyar or anywhere, these are all available. So this is possible that treatment can be done, and there are multiple treatment options. And how will we sequence? Will we have a situation where we can use it for earlier cancers? That has to be seen. And last, screening has to be definitely done. So that is all I have to say. Thank you so much for the patient listening. Thank you so much.